Good evening, everybody. Welcome to our second webinar episode for Peer-to-Peer Academy. If you joined us on the first one, you participated in a really great discussion on light adjustable lens technology. So again, just a recap of what Peer-to-Peer Academy is. What we're trying to do is really develop a community of doctors, both ODs and MDs and upper level technical staff, administrative staff, people involved in anterior segment and refractive surgery. And we're trying to create a community of kind of a hive mind. We want to be able to share ideas on ways to think outside the box. We're trying to push the limits for what refractive surgery techniques and share experiences from real world encounters. And so that's what a Peer-to-Peer Academy is. I definitely encourage you to check out the website peer-to-peer.academy to take a look at the previous webinar if you didn't visit it already. But tonight's going to be a really great discussion. We're really looking forward to chatting about extreme refractive errors, refractive errors outside of just the moderate myopia. We want to talk about high hyperopia, high myopia, as well as astigmatism, and ways that we can manage these things outside of our traditional laser vision correction techniques that we currently have. So throughout the whole discussion here, I definitely encourage this. This works better if everybody's involved. So there's a big white button that says click to submit questions. So if you have questions or comments, I definitely encourage you to go ahead and get those in because we want to engage. We want to be as, this works the best if everybody's involved. So with me tonight, I have a couple people. Let me see here. First of all, I want to thank our sponsors. So number one, RxSight, number two, Star Surgical, and number three, LensR. Without the support of these three sponsors, tonight wouldn't be possible. So just want to say thanks for the support. Tonight, I am joined by three of my colleagues and friends. Number one, John Vukich. John and I have been working together closely for the last 5 years, Summit Eye Care in Milwaukee, Wisconsin. We've built our practice pretty much from the ground up, all things cataract, refractive surgery, anterior segment surgery. So John and I know each other well. Greg, practicing out in San Antonio. Greg is a world-renowned surgeon as well. And then my other colleague and friend, Jenny Wong, practicing in Minneapolis. So really thanks for joining us, guys, and this is going to be a great discussion. So why don't we jump on in? So we want to talk about everything kind of outside of LASIK. LASIK is a great procedure. It's been around for a long time. It's tried and true. We know that it works. We know that it has changed lives, but not everybody is a candidate for LASIK. So John, let me pose this to you first. LASIK is a great procedure for the right person, but when do you start thinking about other options? I mean, who's no longer a great candidate? Has that changed over the last couple of years?
That's really the question that has evolved. LASIK is actually approved by the FDA up to -14. It's one of the few procedures where the parameters that are approved are outside the comfort level of virtually all surgeons who do the procedure. So it's unique in that regard. But the reality is we've learned that there are patients for whom LASIK just isn't the best choice. Corneas that are too thin, refractions that are too high, either in the hyperopic or myopic candidate range. So what is a non-candidate for LASIK? Well, there's a lot of overlap, obviously, but from a practical standpoint, I think, I'd love to hear what Greg has to say about this as well. But I really start thinking about not doing LASIK somewhere between 6 and 8 diopters, which is, clearly within the range that many people are comfortable. You start getting above that and you start worrying about, is the cornea thick enough? Is the residual stroma going to maintain its integrity over the lifetime of this person, often the next 50 or even 60 years of their life? So I think we become more conservative as a group as opposed to more aggressive, which is maybe not a bad thing. But Greg, I'd love to hear your take on this.
Yeah, I agree with much of what you said there, John. Very similar practice patterns with us in San Antonio. I think when I approach anybody that's seeking to see their best without glasses and contacts, there's probably three main things that first come to mind. What's the age, what's the refraction, and then what's the anatomy? So any one of those three things could put someone outside of where we would often think about performing LASIK. So, and there's obvious things, right? So let's take a patient with severe keratoconus. Okay, so that patient is definitely not going to be getting LASIK. Let's take a patient who's 7 years old, too young. The refraction is still developing. And then, extreme refractive errors. And you could define that in any of the kind of 3 meridia of, hyperopia, severe myopia, severe astigmatism. There's limits in terms of what we can expect to accomplish with laser vision correction. So typically, we are looking at performing LASIK in people that are full-grown adults, so generally over age 18. We perform LASIK on people through much of adulthood, including, it's not rare that we would do a LASIK enhancement on somebody who had a lens surgery, whether it be cataract or otherwise. So upper end of age limit is less so. And then, John, I think you made great points in terms of refractions that we'll treat. We generally stop performing LASIK on the hyperopic side around the +3, maybe 3.5 range. And on the myopic side, we really start to favor alternatives. Also, I would say around 8, 9 diopters. It's rare that we do a LASIK greater than 8. And then on the cylinder side, we'll typically treat up to about 6 diopters.
So I think what's really has evolved is that, quite frankly, everything is refractive surgery. Whether patients have cataracts or whether no one really comes in and says, "Oh, you're the doctor. I'll be happy to wear glasses." Everyone has a refractive expectation, and the reality is we can offer a solution for just about everyone at this point. Where now we have technologies that enable us to be so accurate. I'll start with the light adjustable lens, which has really been just an impressive improvement in what we can do for refractive endpoints. And it allows us to be, to let the patient try in advance what they're going to end up with and give a subjective assessment of like, okay, this is what I'm hoping for. And we can adjust that into what the patient wants in terms of their visual quality. And that's been just a game changer from my perspective. So really, we're not turning away patients anymore. What we're doing is we're broadening our perspective. And I think that's the whole point of tonight's webinar, which is, okay, where do you start looking at the division between a cataract solution, which is a lens-based solution, a refractive lens exchange, which is essentially a cataract, and how do you start making those distinctions? And throw out some examples of the 32-year-old +5. What do we do with that patient? Just tell them we're sorry and use contact lenses, or where are the options for that patient?
Yeah, Jenny, let's bring you in from the optometric point of view. I mean, so there's so many different options nowadays where it used to be LASIK or not, and now we have different things that we can do. We have different forms of laser vision correction. I mean, we can consider PRK or SMILE, or there's different things we can do. So from an optometric point of view, how do you present options? Maybe somebody's seeing more primary care. How do you present options to a patient that might be interested? How do you lead that discussion?
I think we have to factor in also their ocular history. Do they have some dryness? Are they contact lens wearers? Things like that. So if they already have some dryness that they're experiencing, then that leads me down the road of probably not thinking about refractive surgery and maybe alternative options instead of that. However, if they don't, then I think refractive surgery is definitely an option.
Yeah, dry eye is a really good point. Greg, what do you think about that? So with other things like SMILE is relatively new and becoming kind of a more common thing, and that's advertised to be less problematic for dry eye patients. Now, compare that to ICL. We know ICL is definitely a great option for our moderate to high myopes, especially those with dry eye. Where do you consider the line to be for those two?
Yeah, so I think first we try to differentiate between, is this a clinical dry eye syndrome in the absence of contact lens wear, or is the dryness that the patient is complaining about more related to contact lens intolerance? So oftentimes just taking contact lenses off will dramatically improve the comfort and the ocular surface. Giving a holiday with contact lenses will often get the patient back to baseline. But in that group, let's say they've taken their contact lenses off and they're still, even in the absence of contact lenses, having, dry eye syndrome that's recalcitrant to, typical drops and therapies. Those are patients that we would generally not perform LASIK on unless we've really been able to optimize the ocular surface. I think that my first choice in that group, provided they're a myope and have sufficient anterior chamber depth, we'd probably be thinking about an ICL. Second line would probably be SMILE for those patients. Let's say their anterior chamber depth won't fit an ICL, or there's just something about them that doesn't like the idea of an implant. SMILE might be a better choice than LASIK. And probably my last choice would be PRK. PRK we've found is really not the solution when patients have dryness. It's pretty much the same as LASIK. Steve Schalhorn has published on this topic, and LASIK and PRK would be at the bottom of my list with dry eye.
So back on the topic of PRK, we had a question just come through. And again, I remind you to click submit question, the white button there on the middle of the screen to submit questions or comments. Do you have limits for PRK as far as refractive or anatomical limitations? Where do those exist compared to LASIK or SMILE?
So in our practice, we generally reserve PRK for lower refractive errors, low myopia. Typically, when LASIK is not suitable, and that might be performing an enhancement on a cornea that's had prior laser vision correction. We generally tend to do PRK in those circumstances. If there's a low amount of refractive error and the cornea looks a little bit suspicious for keratoconus, maybe not frank, like a form-fruste keratoconus, we'll sometimes perform a PRK either in conjunction with cross-linking or on its own and monitor the patient closely. But we generally do not use PRK as our procedure of choice for high amounts of refractive error.
What about pachymetry? Any guidelines for what cornea is too thin for PRK? Any insight there, John? Maybe you want to chime in on that?
Yeah, this is where, so I'm one of the medical advisory board, International Medical Advisory Board for Optical Express, and there's this huge database that is curated from the surgeries that are done in Europe throughout Great Britain as well as in the mainland in Europe. And Steve Schalhorn has done such a great job of extracting information from that. It really turns out that PRK and LASIK are equally vulnerable at the same level. So if you have a cornea that is borderline thin, you do not diminish your chance of developing an induced ectasia by doing PRK, nor do you diminish the chance of there being dry eye or corneal desensitization. Really, the two have always been talked about. It's not what you know for sure, it's what you know for sure that just ain't so. And it turns out that PRK and LASIK actually are really just different shades of the same procedure and have the same level of concern with corneal thickness, which really kind of leads us to the non-corneal options, which really is what we're talking about now. And I think the ICL has been the newest version, the EVO version. If you're not putting that into your practice now, you're really missing an opportunity. You can change people's lives. The ICL is approved down to -3, and I think that many surgeons start using it routinely at a little higher levels, maybe 6 and above. But from a practical standpoint, it is a straightforward procedure that has amazing visual quality. So from our perspective, we really do look at what's going to be a lifetime of good vision. And with the EVO now not needing a peripheral iridotomy and the incidence of cataract, which was low to begin with, now it's virtually close to zero. It's been, and that's just been proven time after time with multiple large studies. So the ICL has become a more important part of what we do, just because it covers those high myopic corrections in a way that gives not only good quality, but is safe. And these are individuals who've been turned down, who are told you can't do anything. Well, that's just not true anymore. That they have that opportunity. And I tell you what, your practice will become a hero within their world if you would do that.
Yeah, I can probably speak to a little bit of personal experience with ICL. I didn't know what ICL was, John, until I met you back in 2019. Yeah, you told me about it. It was before EVO. It just wasn't a very common thing, at least not in Michigan where I was from. We didn't have anybody doing ICL. And we saw, I mean, the previous version did come with some issues. There was a real chance at pupillary block and angle closure, and we saw some of those patients. Sizing the ICL, the Visian ICL, was a challenging thing, and it was kind of hard to get right. But with the introduction of EVO a couple of years ago, I mean, we haven't seen any issue. The lens is extremely forgiving. The eye can withstand a pretty high range of volt. And because of the aquaport in the middle of the lens, there's going to be aqueous flow, which is going to bathe the interior surface of the crystalline lens. So the chance of cataract is almost nothing. The chance of pupillary block is almost nothing. I guess technically you can have angle closure if the lens is just way high volt, but that's really hard to do. It can be done, but you really don't see those risks anymore. And the optical quality of it is just impeccable. I mean, if you look at the FDA studies, how many people actually gained lines of best corrected vision with the ICL after? That, I think it was 52% or something like that, 53%, around there. And why is that? It's really because of where you're correcting the vision. A high level of ametropia, you're correcting at the nodal point, which is right at the front surface of the crystalline lens. And so theoretically, right, if you can correct vision as close to that spot as possible, why not? And that's what the ICL is doing. So we get patients who come in and they're minus 12, minus 13, they're best corrected 20, 25 maybe. And the refraction is always kind of rough because they just eat up minus. But if you get a good fitting ICL and it's the proper power, that patient comes back there 20/20 plus routinely. And it's shifted my thought of where I've got this big diagram, this big Venn diagram in my head when I have a patient coming in for a LASIK consult. LASIK, we've got ICL, and there used to not be much overlap. In my mind, it was LASIK for anybody -7 or -8 or under, and then anybody over that, that's ICL. Well, I find myself having real honest discussions with people as low as -3. If they're -3, they can do an ICL. And there are certainly advantages of it over traditional refractive laser vision correction. And so I have open discussions.
Yeah. How high can you treat with the EVO lens?
The strongest power lens you can get is a -16. And so it's FDA approved for the reduction of myopia up to -20 and the correction of myopia up to -16. We've actually treated several patients that are -20 and even more, and we'll do a bioptics or combination approach where we'll put in a 16 diopter lens and then go back to the cornea to do laser vision correction. So we've got a couple of patients that we took from -20 to 20/20, which is one of the most fun experiences to be able to deliver to people. Yeah. It's incredible. So you think about how you could change someone's life in that way.
Even if you don't have access to an excimer laser, if you take someone who is -18 or -19, what have you, and you leave them a -3, it's changed their life. They're no longer hiding behind these thick glasses that they have limited selection of rims and contact lenses that aren't thick and uncomfortable. So you can have patients who, again, just think you've made their life that much better by making them -3 when they used to be -18. Mm-hmm. So, keep that in mind. We strive for emetropia because we still think about that as the ultimate end goal, which obviously we want that. But, you can leave someone a little bit on the minus side and still be extremely pleased. It depends where they start from.
So what about patients with keratoconus or ectasia? I mean, can you do ICL in those patients?
Yes, we do that routinely. We've published on that actually, and Brett Mueller presented a big paper at Academy a couple years ago with a few hundred eyes where the corneal topography was at least borderline, if not frank keratoconus. It's extremely effective. And, a lot of times depending on the severity of the keratoconus, we might coach the patient ahead of time to say, you might need some thin spectacles or something to wear once in a while. We might at minimum reduce the amount of refractive error, but interestingly enough, the patients often see better than we thought they were going to preoperatively. It's very, very effective in that population.
Yeah, there's one patient we did in particular that I can remember. He was like a -20. He was over -20 and kind of a form fused. His corneas were regular. And I remember he came in, and I'm usually the first person that they see when they come in for any sort of evaluation. And I was like, well, hey, man, we can only get you down to like a -5-ish. and you're still probably going to need glasses. He could not wear contacts. He just couldn't tolerate them. Couldn't get a scleral lens in. He was wearing these Coke bottle glasses that they looked horrible, and he couldn't see very well out of them. And I mean, even though we weren't going to get him anywhere close, in my view, I'm going for perfection. Being in refractive surgery, I want perfect. And this was going to be far from perfect in my eyes, but to him, it was life-changing. I mean, it really was. He could wear glasses now that were at least not highly, you're not inducing so much minification from a -22 lens. He was wearing a -4 lens, and, he was presbyopic too, so he could take his glasses off and read relatively comfortably, at least holding things pretty close. And I think we even eventually got him into a soft contact, if I recall. This was a couple of years ago. But just because you can't get all the refractive error, you can definitely change somebody's life. And I asked him again. I see him now annually. He's my patient. I've adopted him. Would you do this again? Oh, 100%. Doc, you changed my life. And I didn't. And John, you changed his life. But I'm happy to be there for some of the credit. And it is very rewarding. So what about other corneal pathologies like Fuchs? I mean, can you do something like that for Fuchs? Maybe early Fuchs? Is that something that's possible with ICL?
Absolutely. I mean, that is another thing where we know that patients who have Fuchs, they don't do well with multifocal IOLs. They commonly don't do well with LASIK, but with an ICL, they're going to have very high quality of vision, or at least as high a quality, depends on the level of Fuchs, obviously, but it is very high quality vision. And when you do an ICL in a patient with Fuchs, you've not made it difficult or unreasonable for them in the future to have endothelial cell transplant, a DMEC, a DWEC, or other procedures, because the ICL is behind the iris and it doesn't interfere with the corneal procedure.
Does it change how you approach cataract surgery? I mean, it's reversible. Does it change at all the strategy for, a routine cataract surgery and somebody who's got an ICL? Is there any surgical tips, techniques that you guys have?
It really doesn't change it much. A lot of people wonder, can you still get a biometry measurement through the ICL? Is there any sort of nomogram adjustment you need to make with your IOL power calculations? And the quick answer to that is no, it makes no difference. So you can just take a regular IOL master, however you do it, and the ICL in the eye doesn't change those calculations at all. You can also perform femtosecond cataract surgery with an ICL in place. I personally use an ally from Lensar, and we're able to still use the femto treatment right through the ICL, remove the ICL, remove the capsule, and complete the cataract surgery just like we would, with the only addition of slipping out the ICL at the same time the cataract's coming out. I would say the one advantage of ICL in this setting when it's time for cataract surgery compared to the alternative is that since you've not changed the corneal anatomy at all, no induction of any sort of, higher order aberrations to the cornea, the patient's options are maximally open in terms of what type of IOL we may consider for that patient when it's time for cataract surgery. So it's pretty straightforward to perform the procedure. Not many special considerations other than just remembering to take it out.
I think that's one of the most underrated things, that it's hard to explain that to a patient, that once you become cataract age, and especially our ICL patients tend to be a little bit younger, cataract age is just a hypothetical year down the road that they don't want to think about anyways. But having their best interest in mind, cataract surgery at that point, if you're leaving the cornea completely preserved and intact, you have every option on the table. You don't have to worry about something that, uses higher order aberrations to extend depth of focus or anything like that. So it does become easier. What about astigmatism? I mean, how high can the ICL go, and where are you comfortable? Or if you need to leave some astigmatism, where's that line? John, do you have any opinion there?
I believe it's available up to 6 diopters in Europe, and I think what we are limited to 4 diopters now in the U.S. So there's still some envy that we have for our European colleagues, but you can get 4 diopters, and the astigmatic correction is very, very good. So actually, what I wanted to kind of just ask, what about the hyperopes, that we talk about now? And maybe we talked about the high myopes, but, Jenny, you, I think both you and Nick probably together have more experience adjusting light adjustable lenses than, quite frankly, anyone in the country. Jenny, what has your been experience with the hyperopic utilization of the light adjustable lenses, and sort of your experience in terms of patient satisfaction with both distance as well as near?
We've had outstanding outcomes with hyperopic patients where I know I've seen in the past any other lens, you oftentimes see regression or just not even getting the correct power in the lens, and patients are unhappy. With the light adjusting lens, we can wait until everything's stable and adjust it. And we're getting patients down to 2015 and stable we have some that are 3-4 years out now, still no regression and very happy, being able to see distance, intermediate, and near.
So what about, with hyperopia and the LAL, how do you deal with patients who are pre-presbyopic, Jenny? I mean, that's kind of a challenging discussion. Somebody who's in their 30s, let's say, and, LASIK is not an option. ICL obviously is -3 or more myopic, and so that's not an option. For patients who are pre-presbyopic, how do you talk about that? How do you address that?
A lot of them already, I feel like, are struggling to see up close. So they know a lot of my patients in their 30s are already using some type of readers. So they're already struggling at that point. I just let them know once you have this lens implanted, there's going to be at least 2 to 3 weeks where reading is going to be difficult. You're going to need a higher power reader temporarily, but then we are going to adjust the lenses and you're going to be able to see all of your functional needs, like your phone, computer, and everything fine with that.
Do you take multiple times? I mean, so personally, when I have somebody who's coming in and they're hyperopic, and let's say there's one patient in particular that I'm thinking of. We did a 29-year-old girl. She was +8 with 2 diopters of cylinder, and she was a news anchor. And so she's in the public eye. And so we obviously want to make sure she's very happy. So she's got a very big network. We want her to share, obviously, and make us look good. So with her, I took extreme caution to explain to her that needing reading glasses is probably going to be necessary on some level. Now, not for everything. With the LAL, it does a fantastic job of expanding depth of focus. And if you do a little bit of a blend, you can make people very functional without glasses for most activities, but inevitably you're going to need reading glasses for some stuff. And that's just the reality of it. So for her, I think, John, you and I both talked to her on several occasions to make sure she understood that. I didn't want her to be unhappy. How do you bring them back? Do you do phone calls, Jenny, or how do you guys do that?
I do. And I also, like for that patient specifically, probably would have extended her treatments a little just to make sure everything was stable. I also find that hyperopes sometimes take a little bit and then they'll absorb more plus, after their second or third visit. So I want to make sure I'm not missing that. So sometimes I will do a treatment. I'll do a refraction, have them come back the following week. So there's like 2 weeks in between a treatment just to make sure. But I also, I let them know you can have them test it with some contacts before just to make sure that they understand what the amount of reading that they will have, and that their working distance will also have to be altered along with the amount of light that they're using. So I think setting realistic expectations and then hammering that in each time just as a gentle reminder so that they aren't harping on, I'm not able to see that tiny, tiny print on those bottles, just focusing more on the positive too. Like, are you able to see your phone? Can you see the computer? Those are the major things that we want to make sure that they're able to do on a day-to-day basis, as opposed to reading that small text in dim lighting.
Greg, what do you think? Any tips, strategies that you do for the hyperopes?
We love RLE for hyperopia, and we go pretty young with it too. So, we've performed RLE on high hyperopes in their 20s and really had incredible results from that. And I would say that one of the things that we pay attention to, and not just the hyperopes, but all the patients, is what's their current method of optical correction? Because a glasses wearer that's a +8 has kind of a different life and a different experience than if they're wearing, contact lenses. And so trying to get an idea of like what their daily routine is used to for reading. Do they have that kind of edge glare off of a high plus spectacle lens, or is it contact lenses? So that kind of goes into how we're coaching the patients on what they should be expecting in terms of how the surgical outcome is going to compare to what they were used to. But I think, whether it be a lens replacement using an LAL for a hyperope or an ICL in a young myope, the point that, I think, John, you mentioned a little while ago is that, we do have so many options today to help people get out of glasses and contact lenses if that's what they wish to do. And it's really not just LASIK and PRK anymore, even though that's what most patients think. So one of the most important strategies or tips I would share is, when patients call the office and say like, hey, I want to come in and get a consultation for LASIK, or oftentimes they'll even ask the question like, hey, how much is LASIK? The first response to that question, even at the level of the phone, is, that's a wonderful question. Have you actually been evaluated to find out if LASIK is the right procedure for you? There's several different procedures we offer. Some of them are laser based, some of them are lens based, and we'd really like to do an assessment of your eyes before we can make a recommendation around which of the different procedures we're going to do. And just floating that concept that it's more than just laser vision correction from the very first interaction with the practice, then continued through educational content that they get, via videos and apps to their phone. When they come in and meet with our staff, we're always talking about there's many different ways to correct vision, and it's not all just LASIK. And so getting that information about these lens refractive surgery options out there early and often can make a big difference in terms of patient adoption of the procedure that's best for them.
That's a great point. Can you talk about, so a short eyeball from somebody who's maybe some of our optometrists out there who aren't necessarily involved in refractive surgery, why is a short eyeball difficult to work with? Why are we more likely to miss?
Well, the surgery itself, I would say, can be slightly more technically challenging just because there's not as much room there. So like physically, when we're operating in the eye, there's a shallower amount of depth between in the anterior chamber. And so it's a little more crowded in terms of, doing the procedure that we need to do. And I think I would also say in terms of like predicting the power, maybe that's what you're getting, like hitting the target with the lens power. John, you may have a better answer than I do on this, but what I would say is likely is that, super high refractive errors, like super high hyperopia, is such less common than, typical refractive errors. And so some of the mathematical formulas that we have to predict the power of lens needed to implant in the eye are less sophisticated than a typical eye. So you're just based on bell curves and statistics, there's more variance in those super high ranges on the IOL side.
Greg, you're 100% accurate. That's exactly right. And one of the reasons why it is less accurate is not only are there fewer of them to like really be able to refine the algorithms. One of the main issues is that we've got a high-powered lens, just by definition, that you're putting in, plus 30, plus 32, whatever, and the effective lens position is less predictable. There are hyperopic eyes that have relatively deep anterior chambers, and there are hyperopic eyes that have relatively shallow anterior chambers. So the two aren't necessarily lockstep. And so the simple math on this is it's 7% of the IOL power for 1 millimeter of change. So 7% of a small number is not that much. 7% of a 30 diopter lens is enough where you can be off by a diopter and a half easily. And for no other reason than you can't really know where the lens is going to set. And so that's where the light adjustable lens comes in. It gives you that refractive capability to say, all right, no matter what, we're going to end up with a great outcome, because I use a golfing analogy quite a bit, which is on a par 3, if you get the ball on the green, you've made a good shot, but you don't expect to get a hole in one. With the light adjustable lens, I'm going to get it on the green, but now I've got 3 putts, not 2. I've got 3 putts, and my target is now 5 inches across, and we're going to hit it every time. And so I say I'm using that euphemistically because, quite frankly, it's Jenny and Nick that are really doing the heavy lifting, making sure the patients get the great result that they do. So it is a team sport in that regard.
I'm better at this than I am at putting. Unfortunately, I wish I were a better putter, but I am terrible at putting. So going back to the example I gave my 29-year-old patient, John. So with her, there was a couple of reasons why we didn't go with like a multifocal or an EDOF lens, mainly because we just didn't think it was going to give her the results that she wanted. Now she's a young girl. She's got big pupils, and she's in front of a stage. She's in front of studio lights all the time. That's her job. That's going to be miserable. I mean, if she's not tolerant of the dysphotopsies that naturally inherently exist with those lenses, that would be a problem. So we went with the LAL, and we went in with the idea that we would do a blend. We'd do one eye as plano, and then we'd probably end up somewhere at -1 or so from her non-dominant eye to get her the ability to see her phone when she's doing on-site reporting and doing, anchor desk work, so she could see her papers and definitely see the teleprompter without having any dysphotopsias. Now, the problem with her during the process was that we ended up, because she's got a really short eye, we ended up +2. And imagine if we didn't have an adjustable lens, it would have been disaster. She was in tears. She came in, and I had talked to her many times, and we developed a pretty good rapport. But she was in tears, and I'm sitting there thinking, like, holy cow, yeah, this is going to work, right? This is going to work. We're going to fix this. And she had brought her mom, and her mom was in from out of state because she was just not in a good mental spot. And I guess fast forward, I wouldn't share the story if it didn't end on a high note. She ended up wonderfully happy. I mean, she was plano in one eye, -1.25 in the other. She's fully functional. She wears reading glasses for real small stuff, but that's about it. She's one of our biggest advocates, and she did a wonderful testimonial for us that has hugely helped the practice. It's got thousands of views on YouTube. So that story, I think, is so indicative of what can go wrong in a short eyeball. I mean, we had a great surgery. It went beautifully, but she still ended up +2. And we had the highest lens that we have. Our Excite, the lens is produced up to 30 diopters. We use bilateral 30 diopter lenses. We couldn't go any higher. So yeah, it's a fun story I like to share. Now, on the flip side of the coin, the high myopes. I mean, we talked about ICL, but where's the limit with who's not an ICL candidate? There are limitations there, and patients who you can't do ICL, you can't do LASIK, then what's left? Is there room for LAL in this category? I'll open it to the
Shallow
floor.
anterior chambers. We see patients with 2.8 millimeter chambers, and you can get the ICL is approved with 3 millimeter chamber, and again, it is off label, but in Asia they do 2.8 and above, and it's not that different. So they're getting great results doing literally millions of lenses. So I'll go down to below 3.0, but once you get below 2.8, the wheels kind of potentially fall off, and I think you need to be very careful about that. So there are patients for whom a refractive lens exchange now becomes, the best option, and that's where the LAL comes into play as well. Greg, you are probably one of the most prolific ICL users in the country. I mean, you've been so great at making this well known in your area. People come from all over the country to see you with good reason. So what are your thoughts on, where do you say, that's not going to work, and now we're going to change to a lens exchange?
Well, same scenario you just mentioned is when the anterior chamber depth isn't sufficient to fit the ICL safely. And then the other parameter I would say is, when they're getting closer to cataract age, if it's only going to be a few years before we think we're going to have to go back in the eye and do a cataract surgery, it probably makes more sense just to go straight for the lens now. So it's, I've definitely done ICLs for plenty of people in their 50s. I don't think I've ever done one for somebody in their 60s. So probably 60 and up, even if they're a higher myope, I'd probably go for an RLE.
So, John, you mentioned the label says 3.0. In Asia, it's 2.8. Well, I got to ask, what about 2.79? At what point, where is the definite line? Do you start thinking of, is there angle issues then? What other metrics are you looking at? 2.78.
Well, yeah, I know. We can play this game. It's like playing game chicken, right? Just because you can get away with it doesn't mean it was a good idea. Really, at the end of the day, what matters is the angle compromised or not. If they have an angle that is sufficient, even doesn't matter what the vault is. If the vault is a little higher than you expected or a little lower than you would hope for, if the angle is open, really the question is, are they going to have pressure issues, or is there going to be iridocorneal touch peripherally and some accelerated endothelial cell loss? And you really don't see that until you get below, say, 12 degrees angle. If you have anterior segment OCT, you can measure it. So my common sense measurement is, if someone who had never seen an ICL before looked at this patient for the first time and looked at a slit lamp, would it call their attention? Would they look at that and go, "Ooh, boy, there's a problem here"? And that you don't have to measure it to know that. You've done tens of thousands of eye exams, and you look at someone with a narrow angle, and you'll see it, you'll notice it, and that's the angle that's too shallow.
Yeah, I agree with that, John. The other thing I would say is that oftentimes the cause of a low anterior chamber depth is actually a very large crystalline lens, or a crystalline lens that has a significant anterior capsular lens rise. So there comes a point where you can't get both an open angle and a significant enough vault. So the other, even if I had an open angle, I also don't want the ICL sitting flat on the crystalline lens. So it just needs to be, at some point, there just needs to be enough room to fit all of that volume into this space we're working in.
Good point.
I want to share just a short anecdote, if you don't mind.
Sure.
So I love the Hawaii meeting. If you've gone, you understand. If you haven't, I'd recommend it. But I've been, lucky enough to give talks at that meeting in the past, and the moderator for the session contacted me. Vance Thompson called me, and he said, "John, we'd love to have you talk again this year. And here's my only request: pick something that you're passionate about, and pick something that has changed the way you think about treating patients, and I want you to talk about it." And it's like, okay. And it ended up being easy. So the title of my talk is Rediscovering Flax, Confessions of a Former Disbeliever. And I was absolutely, I was part of some of the initial studies with femtosecond lasers, and quite frankly, I sent the laser back when we were done. I just didn't think it was an expensive solution to a problem I didn't have, and did that for a number of years. And I have since now completely changed my opinion. And you mentioned you're using the Ally system. I am as well. It's a lens AR system, but I think the other systems are probably as good, but the one I know about is the Ally. And right now we're doing like 35–40% of our patients are getting flax. And the reason is we're treating lower levels of astigmatism. And so, I'm kind of use this common sense where, would you prescribe glasses and forget about treating 3/4 or 1 diopter of astigmatism? Would you do that? And the answer is no. And if you're putting in a standard lens because you can't do a toric, you can treat that with the femtosecond laser. And, again, times being what they are, you can bill for that, and it becomes, one, a great asset to the patient in terms of the quality of vision, which is clearly better for having mitigated the astigmatic correction that they would otherwise have. And two, it's been a plus to the practice. Quite frankly, it's a center in which we have a premium option that people can afford. If they can't go for the other options, they can generally afford the AK option or with the femtosecond laser. So that's been one of the game changers for me, and I just had to throw that out there. And I don't know, Greg, what do you think? I mean, I know you use it as well, and
yeah.
What are your experiences been?
Yeah. So we're a big believer in the benefits of femtosecond laser cataract surgery and femtosecond laser RLE lens replacement as well. So we choose to use it for every RLE that we do. I really believe that it is a safer alternative to manual cataract surgery. And that is not to say that basic cataract surgery isn't safe. It's a wonderfully safe procedure. But if you made me say, which one do I think is safer? If I had to do 1,000 cataracts, would I rather use it or would I rather not? There's no doubt in my mind I would rather use the femtosecond laser on those 1,000 cataracts. There's so many things that you can mitigate that otherwise might make a cataract surgery challenging, whether it be a white cataract, a loose zonule, a patient who's moving around. I had a cataract surgery a few years ago. This was a case I didn't use femto on. And as I was starting to do the capsulotomy, the patient developed a pretty severe case of the hiccups. And so as I'm peeling my capsulotomy, I had to time it and hiccup and then pull a little more, hiccup, pull a little more. I mean, there's just things you can't predict what might be the reason you're glad you had the femto that day. but there's many of them. And from an astigmatism management standpoint, I actually do think the Ally platform does have benefits compared to the other systems, primarily because of its iris registration to the clinic diagnostic capability. So we use a pentacam. There's several different other diagnostic devices that can upload a photograph of the iris along with the astigmatic axis of the cornea. That data gets uploaded to the Ally system. And then with iris registration, when the patient is docked underneath the laser, it also sees that same iris registration detail and auto rotates to put either the AK on the cornea and or the toric lens in the exact axis of corneal cylinder. And there's no other platform that has that amount of astigmatic precision.
That's an incredible feature of the unit, though, because I mean, think about there's a stat, and I don't remember the exact number, but the amount of average cyclorotation by placing just somebody's head going in a supine position, it's several degrees that you can actually have cyclorotation. So from an optometric point of view, I mean, Jenny, you know as well as I do, a contact lens that rotates 5 degrees, especially in somebody who's got a diopter or two of astigmatism, that's a problem. You know, we have different ways to compensate for that with contact lenses, but in surgery, you really don't. If that lens is off by 5 degrees, there's only one way to fix it, and that's to go back in and re-rotate it. So the ability, I think, to get astigmatic correction and management on the degree of axis, you know, without having a whole lot of deviation is just huge. So talking about the different technologies we've already hit on a bunch, Jenny, maybe you can comment on this. I mean, using a femtosecond laser assisted, astigmatic correction with the LAL. The LAL does have certain limits. So can you talk about the limits of astigmatism inclusion for LAL and how we can...
So with the LAL, we can treat down to 0.5 diopters of astigmatism, but up to, I've really pushed the limits and I've hit 350, but sometimes, you know, things go awry and we have, you know, they find out that there's more. I think that the AKs and LRIs really help those patients with the higher amount of astigmatism. So a lot of our surgeons are already just proactively using that so that I don't have to try to cross my fingers and treat that amount of astigmatism each time. So it's been very helpful and a game changer.
What do you think? When do you start recommending? I mean, at what level? If somebody's got like a diopter and under, or diopter and a half and under, you forego AKs?
I say 150 and higher will just kind of help the patient's journey a little bit quicker, just because with the light adjusting treatments, 175 and higher usually will take multiple treatments to get down to plano then.
Yeah, so what you're doing, if you can debulk astigmatism at the plane of the cornea, so patients who in our practice, anybody who's a diopter and a half or more, we'll always recommend a flax treatment, and we use that pretty routinely. But really pushing for it in patients with a diopter and a half or more, because if you can get that down to a more workable value, you're preserving the finite number of macromers that exist in the lens. Remember, that lens is made up of a finite number of macromers, and the more you use to treat astigmatism, the less you have to move in a plus or minus direction. So you want to preserve that number if possible. So a diopter and a half is kind of where we put it. I mean, I could definitely see an argument for even less than that. Just to give yourself enough wiggle room if you need it. So a short eyeball, if you got somebody who's like my +8, patient, that if you're going to be off, you may need more macromers to work with. So maybe more quickly go towards an AK inclusion. So back to astigmatism. I mean, at what point with not doing the LAL, if we're doing just a monofocal lens, is there a difference with how you manage astigmatism based on the degree, with the rule, against the rule, oblique? When do you consider when it's worth treating? Greg, maybe you can start there.
Yeah, so there is a difference between with the rule and against the rule. So that has to do with where we're sitting and where, typically I sit temporal. I think most cataract surgeons sit temporal these days. A few will sit superior. But if we're sitting temporal and we want to make an arcuate incision nasal in an against the rule case, it can only be so large, and so we have a different threshold where we'll go to a toric lens if it's an against the rule patient. So we might put a toric lens in even if there's only about 0.8 diopters of against the rule astigmatism. Whereas if it's a with the rule patient, we'll put a toric lens starting at about 1.5 diopters. And less than that, we can use arcuate incisions to reduce the cylinder. So there's definitely a difference there. And then to your question about like, well, how much should we treat? I mean, I go back to, the point that you made, John. If it's enough that I would put it in a spectacle lens, why wouldn't I put it in something permanent like a surgical lens that I'm prescribing to the patient? I want the patient to have the absolute best quality of vision. I think that, as you mentioned earlier, Nick, treating refractive error closest to the nodal point of the eye produces the best quality of vision. We see that with high myopia and ICLs compared to treating the cornea. Same thing goes for astigmatism. If you can treat that refractive error closest to the nodal point of the eye, you're going to produce a better quality of vision than you would if you put it, like half inch in front of an eye in a spectacle lens.
Yeah, I think those are all great points. I mean, the ability to treat astigmatism, and you can almost like kick into the wind, right? Based on their age and where they're going to probably drift. And I think that's kind of where we are in our practice too. If it's against the rule, we're more likely to do something quicker. If it's with the rule, we usually can leave a little bit, expecting them, depending on their age, where they're going to drift and how they're going to change. John, talk about how you present that to patients. How do you even present astigmatism? That's such a big word. Everybody thinks it's almost the equivalent of cancer, right? It's just a terrible thing. How do you talk to patients about it?
Most patients, they may not understand what astigmatism is, but they know that their glasses were a little bit more expensive or their toric lenses were special and had to be fit specially. And so it's just another component of what makes a blur. And then I'll meter the technicality of the discussion based on, what the patient really wants to hear. And you can get as wonky as you want, but I try not to overload them with, what the optical issue is, other than it's just one more thing that creates a blur. And unless we correct it, you will not have clear vision without the need for something to correct it. So I try to keep it simple, and I've established, kind of a sense of what patients want to hear in terms of how deep you want to dive. But I will certainly tell them, again, as we've mentioned before, that, look, you've had this correction in your glasses, in your contact lens. It's always been there, and it's there for a reason. And we're going to do the same thing with your implant or with the correction of the astigmatism using a laser, which is very accurate, and that will give you the result that you're looking for. And so really, at the end of the day, I don't think patients care how it's done. I think they care about the result. And that's what they'll remember, is the end result. And that's what creates patient satisfaction and word of mouth referrals. And I guess I can tell you that 2 years ago, if someone had asked me, well, do you think you'll ever really use a femtosecond laser in your practice? I probably would have said, there's no way. I'm doing just great. Thank you very much. And it is now an incredibly important part of what we do. I mean, like I said, it's like 30 to 40% of our cases are done with a femtosecond laser. And that is only driven not because it's a marketing tool or not because it's a laser. It's because we're getting better results. And that is, the end of the day, what you need to be able to do. And this is what allows us to get that result.
It's incredibly important, especially in so many, John, you as well as I know, that most of our patients are post-LASIK. And some of the LASIK that was done 20 to 30 years ago was pretty aggressive. And there's a lot of higher order aberrations in these corneas. So the ability to have a central capsular rhexis, have a lens that's not going to be tilted, you're not going to induce coma, you're not going to have as much trefoil. It's just imperative. And now we have technology like the LAL that we can really modify things. However, the lens still has to be centered, and that's where the capsular rhexis comes in play. So many of our patients have these corneas that have already been not screwed up, but they've been amended, and they're dealing with maybe not, Well, I mean, looking back, I wish you hadn't had the LASIK, because this makes it a lot more challenging. But now we have the ability to really, address it and modify it. So we're kind of coming in towards the last couple minutes. I want to get to some of the questions that we've had. So number one, Jenny, I'll start with you on this one. We'd love to hear how you approach hyperopes and post-RK patients with the LAL. How do you manage this? Does it change? Have you changed any of your process?
I do change my process for RK patients because their corneas are so unstable. We don't actually start treatments until at least 2 months post-op. I do get 2 refractions before that, but starting any earlier, we found that patients were having regression after we locked them in. But starting at that 2-month mark and then going every 2 weeks. So 2 weeks, we would see them to get another MR check, 2 weeks, then another possible treatment instead of doing it weekly. So it's almost 1 month between treatments just to make sure everything is stable. And we have seen 2015 J1 plus in almost all our RK patients now. It's a
Yeah,
very good option.
I would echo that. I mean, RK is the second follow up to that question was, does this exclude, or do you exclude RK patients from the LAL? And absolutely not. I welcome it. When I have an RK patient come in, we're going to strongly suggest the LAL. They do very well. It does take longer. We do extend the process a little bit more, but they do end up very well. All right, second question. John, maybe you take this one. How do you manage patients who have AMD? Because on the label it says AMD is a contraindication to the LAL. How do we address that?
Yeah, that's actually interesting because it is definitely a contraindication for multifocal lenses. You really don't want to put a multifocal into someone who's got dry or certainly not wet AMD. I would actually do the exact opposite. In fact, we get referrals from retina specialists now who are recommending the LAL because you don't know what that patient is going to like when they have AMD. You don't know where they want to be and to get the best quality of vision, knowing that it's going to be compromised and you're not going to get a perfect 20/20 result because that's just not possible. But what you don't know is what refraction they're going to want. Do they want to be a -2? Do they want to be emmetropic and plano? And it's a real quality of life issue that gives that ability to not for us to predict what we think they're going to like. It's for the patient to say, no, this is actually, this is good. This is as good as we can get. So I think the LAL is, yes, the label says it's not indicated for patients with AMD. I would actually say that is wrong. This is specifically what we recommend as the best option for quality of vision.
And to add on that, we actually have patients that have wet AMD and are actively having injections between their treatments, and they're doing fine. So it's opening the doors for them too, because otherwise they would be just locked in with the traditional monofocal and have glasses full time.
What about from a retinal health standpoint? Is there any concern with UV light exposure to the retina exacerbating AMD?
There's UV block on the back surface of the lens. That's been looked at. It's a legitimate question to ask, but the reality is the lens has safety factors built into it. The amount of lens or the amount of adjustment and illumination that you can provide is gauged to be within ANSI standards for safety. So the answer is no. I think the biggest risk for the AMD patients is you're not going to get them to the optimal level of vision to give them the increased quality of life by just putting in a standard implant and guessing where they want to be. You can improve their quality of life with an LAL. There's no question in my mind.
Yeah, I agree. One more quick question. So, Greg, how about this? How about I shoot this one towards you? If you're using the femto, the LensR system with LAL, do you change the way you charge patients for that, or is it kind of baked into your price?
So the way we charge is for if we're doing astigmatism management at one vision zone, like far or near, whether we use a toric IOL and or a femtosecond laser, it's the same price. So we don't piecemeal it or a la carte a toric different from a monofocal when we're treating one vision zone. When we're treating more than one vision zone, we have a different price. So if, for example, if we're using an extended depth of focus lens or trifocal lens, that's its own price, and adjustability is the third tier. So we charge more when we're doing an LAL than we do when we're doing a trifocal, which is more than when we're just doing one vision zone.
Yeah, that's how we do it too. We don't really a la carte it. I don't think that's necessarily, it's not something I would recommend doing, but it's all, we're trying to get to the outcome. The patient doesn't really care how we get to the outcome as long as we get there in the safest, most efficient and effective way possible. So we bake it into our prices. It's not, we're not adding the option for the laser and passing that along to the patient. Well, we're coming up on about an hour, guys. I just want to say thank you again so much to our sponsors, RxSight, Star Surgical, Lensar. Without their support, tonight couldn't be possible. And thanks to our speakers, Jenny, Greg, John. This has been great. And all the questions that were submitted. This discussion was fantastic. Hopefully everybody got something out of it. I know I did. We're going to have another one in about a month. So Tuesday, November 12th, 7 p.m. Central. And we're going to do these monthly, different topics, different ideas. If you have any suggestions, feel free to pass them along. We'd love to hear where there might be a need for open discussion. So keep an eye on your inbox for those details to follow. And thanks again for everybody joining us tonight. Have a good night.
Thanks,
Thank you.
everybody. Good night. Thank you.
Bye.